Thank you for joining Cancer Support Community Atlanta for Radiation Oncology 101, facilitated by Dr. Isabella Zhang with Northside Radiation Oncology Consultants and moderated by Dr. Sanjay Vin with Atlanta Cancer Care. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. If this is your first time participating, we invite you to complete a new attendee form to stay connected to all future programs.
Welcome everyone to today's program, Radiation Oncology 101, with Dr. Isabella Zhang and Dr. Sanjay Vin. I'm Katie Armsby, the Program Outreach Director with Cancer Support Community Atlanta. If this is your first time participating in a Cancer Support Community Atlanta program, we welcome you and invite you to visit our website, cscatlanta.org, where you can see a complete list of the virtual oncology programs offered. These include virtual support groups led by licensed mental health professionals, stress reduction classes like yoga and Tai Chi, a monthly nutrition seminar facilitated by an oncology dietitian with Northside Hospital Cancer Institute, and education programs like these. And if you ever miss a live event, we invite you to visit the video tab of our website where you can find recordings of past programs, and those do include yoga classes, guided meditation, some other stress reduction classes as well. So again, to register for any of our live programs or to check out any recordings, please visit our website, cscatlanta.org. As a reminder, everyone will remain on mute for the duration of today's program. We invite you to enter questions into the program chat box, which will be addressed during the Q&A at the end of the program, time permitting. I'm excited to welcome today's program moderator, Dr. Sanjay Vin. Dr. Vin is a board-certified physician in hematology and medical oncology, specializing in breast cancer, lung cancer, genitourinary, and gastrointestinal cancers. He's been a principal investigator for various clinical trials and has published multiple peer-reviewed articles. Dr. Vin practices with Atlanta Cancer Care at their Forsyth and Canton locations. Through his commitment to treating the whole patient and not just their disease, Dr. Vin is driven to seek all available avenues and resources to best care for his patients. So with that, welcome, Dr. Vin, and I will pass it off to you to begin today's presentation.
All right, thank you, Katie, for the introduction. It gives me great pleasure to introduce Dr. Zhang as my colleague. I worked with her with several patients, and she is board certified in radiation oncology, where she graduated from Northwell University in New York. She works with Northside Cancer Institute and with Radiation Oncology, and also co-director of Gamma Knife. During her free time, when she finds actually, she likes to bake and kayaking and photography. I've never seen those pictures, but I'm sure she does well, and I'm going to hand over to her.
All right, thank you both. Thanks, Katie. Thanks, Dr. Vin, for the introduction. Just want to say hi to everybody and say thank you for joining us during your lunchtime today. I wanted to really just say thank you and introduce you guys to what to expect when you are referred over to a radiation oncologist or when you or a loved one are going through this process. So this is really just an introductory session. There is a question and answer option, so please feel free to ask questions and we'll address those at the end. As Dr. Vin said, I'm a radiation oncologist here at Northside Cancer Institute, and I'm also the co-director of our Gamma Knife program here, which I'll discuss towards the end of the presentation. I have no disclosures. First, I like to start with kind of the big questions that people ask or expect when they come here, to say what radiation oncology is not. So a couple of ones I get asked more commonly than you would think. One, we don't use lasers to treat patients, nothing like that you'll see here. 2, we definitely will not make you glow in the dark. And 3, I have actually never given anyone any superpowers, and I don't expect that to happen. But if it does, please let us know. What we actually do at radiation oncology or radiation treatments are, we use highly focused radiation therapy to help patients with cancer in both the curative and the palliative setting. And in some cases that I'll describe, we treat benign conditions as well. Radiation is one of the major parts of the overall oncology treatment. So the ones that you've probably heard of a little bit more are surgical oncology, and that's pretty easy to picture, to explain. This is where you meet with a surgeon to either biopsy your tumor or to remove it with surgical resection. Here, the easiest picture is with a tumor in the lung, where if you see a surgical oncologist, they're able to take it out, they would resect it, and you may need us in the future or a medical oncologist. A medical oncologist is somebody who usually prescribes you chemotherapy, systemic therapy, immunotherapy, and even hormones in some cases. And Dr. Ben's one of our medical oncologists who would be able to speak further to that. Systemic therapy or chemotherapy often goes to the entire body. And in this depiction, you can see where that chemo would go and really reach most parts of the body. What we do with radiation oncology is we usually target a small area of the body, much like the surgeons do, and we target that with radiation, either for curative treatment or palliative treatment. And surprisingly, although many people have not heard of radiation oncology until they go through this process, about 60% of patients do see a radiation oncologist or receive radiation treatment at some point throughout their course. When I talk about our types of therapy, I'd mentioned that we do provide curative treatment. And curative treatment, the goal of that is to completely get rid of the cancer, to kill the cancer and reduce the chance that this can come back in the future. You can see from this list that we treat pretty much every cancer from head to toe, starting at the very, very top with head and neck cancers, all the way down the body, and including skin cancers, cancers of the muscle or the bone, and also lymphomas. Here I use a little some abbreviations you'll see a little bit later as well. So GYN cancers, gynecologic cancers such as endometrial, vulvar, vaginal cancers, and GU, genital urinary cancers such as bladder, prostate, and testicular cancers. A big part of what we actually do is also palliative treatment. And what palliative treatment is, it's to help with patients who are developing symptoms from their cancer, such as pain, bleeding, and radiation itself can be very helpful in these situations. One of the most common things that we do see is bone metastases, where cancer has spread from one part of the body to the bone, and that can be quite painful, quite difficult to manage with just pain medications alone. So this is a common thing that we see and see very good success with treating with radiation. Another site that we treat pretty often, and that's because of the Gamma Knife program that I'll discuss in a little bit, are brain metastases, where cancer has gone to the brain, and we can help control these areas and also help in cases of symptoms. Other things, like I mentioned, we can help with neurological symptoms if a tumor is compressing the cord or any kind of nerves. We can help with breathing if cancer is compressing the airway or the lung, and also with bleeding if the tumor is going through the skin or any kind of soft tissue. And a growing part of our field is treating what we call limited metastatic disease. This is somewhere in between that completely curative and also palliative world, where we're able to treat sites of limited metastatic disease, usually 1 to 5 sites, although that number is always changing, to help prolong the time to any additional chemotherapy treatment or really keep that cancer from growing. We also do see some benign conditions, and I like to just bring this up because when patients with benign conditions are referred to a radiation oncologist, they often panic. They say, "Nobody has told me that I have cancer. I didn't realize, I didn't know why I would be coming to see you." So I do want to mention that we treat multiple benign conditions, from keloids, which is just overgrowth of scars. We treat patients who are undergoing hip and knee replacements to help reduce the chance of bone spurs, and that's the heterotopic ossification. Since we have a large brain tumor program and many of those tumors are benign, non-cancerous tumors, we do see a number of those, such as acoustic neuromas, also known as vestibular schwannomas, and other benign brain conditions. One of the functional disorders we treat is also trigeminal neuralgia, which is facial pain due to aberrant signals from the trigeminal nerve. And one of the areas that's growing rapidly, I think this has started ever since even I've been in residency, is treating cardiac arrhythmias with radiation therapy. That's something that's definitely a growing field. One of the big things that I do get asked is, how does radiation actually work to treat my cancer? And this is probably one of the simplest depictions, is of radiation damaging the DNA of a cancer cell. When radiation does this, it prevents the cancer cell from being able to reproduce, being able to grow. And when that happens, the tumor does tend to slow down its growth and eventually die. Cancer cells usually reproduce or grow at a higher rate than your normal cells. So when you have this damage to your DNA, it tends to be taking up more and affecting more of those cancer cells than your healthy cells. Secondly, cancer cells often don't have the same DNA repair mechanisms as your healthy cells. So once you do have this damage, they're less likely to repair themselves than a healthy cell that can tolerate this type of DNA damage. Additionally, radiation, when given at higher doses, can be considered ablative. So instead of just waiting for the DNA to be damaged for the cells to grow slower and slower, radiation can actually work by killing off the vascular supply. Here you can see the blood vessel supplying this tumor right here, where it can actually decrease the blood supply to the tumor and more quickly decrease that tumor growth or cause that tumor to start shrinking. The dose of radiation that you actually receive will depend on the type of cancer that you have, and it may depend also on where that cancer is. If it's close to something that's very sensitive to radiation, that may limit our doses, or if it's far away from anything that's very sensitive, where we may be able to give a higher dose in this ablative way. So that was really the background of what radiation does, what it looks like. A big part of what I wanted to do today is take you through the process of what you would expect once you're referred over to a radiation oncologist and the treatment process. I will start off with saying this is pretty general and also mostly explains the external beam radiation therapy process, which is the vast majority of what we do. I'll discuss a little bit about the internal radiation, which is also known as brachytherapy, but this process will be mostly directed at that external treatment. The first step is actual consultation. This is where you meet with your radiation oncologist who you're referred to. We will review your records prior to when you come to see us. We'll look at what images you've had, what biopsies you've had, what surgeries you may have had already, and discuss with you how radiation may play a role in your treatment course. At this time, we'll kind of give you this introduction overview as well, discuss the side effects that you may expect with a treatment, what length or duration treatment may be. And after you discuss with your radiation oncologist and together make a decision as far as treatment, your radiation oncologist or his or her team will coordinate with your other doctors, your surgeon, your medical oncologist, as far as what treatments have to be in which order and what will go together. After your consultation, if you're going immediately towards radiation, the next step will be a CT simulation. This CT simulation, which you may also hear is called a mapping session, is where we actually set you up in the position you'll be treated during your radiation therapy. In this picture right here, you can see a couple of different options that we have, where in the back of her right here, you can see that khaki colored mold, and that mold helps keep you in position during your radiation treatments. It makes sure that you're in that same position every day, that you're not rotated one way or the other, and that you fit comfortably in that same spot. What you see additionally is that this kind of bar over the stomach, which you may require for some specific lung treatments or upper GI treatments to help reduce how much your tumor is moving when you're breathing. On the right here, I also wanted to show you what it may look like if you're receiving any kind of head and neck or brain treatment. This is a little bit of a scarier looking contraption, but it's a plastic frame that we actually use heat, either a hot water bath or a heated oven, to warm up that mask, place that over your face and kind of mold that around your face. You will be able to see through it and you will be able to hear through it. And it's actually a very effective way of keeping you still if you are receiving any treatments from the neck up. During the CT simulation or mapping session, we will also be doing a CT scan in this position, and that CT scan is done so we can do our radiation planning and be able to target your specific anatomy and your specific tumor. On this day, you may also be getting a couple of Sharpie marks on your body to help line you up, or a couple of tattoos on your body that help line you up when you come back for treatment. This is one of the questions that I do hear often. Do these Sharpie marks or tattoos actually direct where the radiation is? And I have to say, no, it doesn't. It helps us line you up on a day-to-day basis, but you are not getting radiation to those tattoos or kind of where that's triangulated. So that's a common thing that I hear. After your CT simulation, you go home, and this is where the behind-the-scenes work happens with your radiation oncologist and your treatment team. So the next step that we go through is called treatment planning. So this is where we take the CT scan that you had on the day of your mapping in that position you're being treated in, and we actually draw out where your tumor is and draw out the things, the healthy tissue that we want to avoid. We work with a dosimetry team as well as a physics team to make this happen. Normally, when I see patients for consult, I do like to ask if they've had any experience with radiation before, either personally or with any kind of family. And the reason I ask this is many patients will have had some sort of experience with either parents or grandparents, and radiation was very different 10, 20, 50 years ago, and some of the side effects would be different. I wanted to really graphically depict this to show you what some of these changes have been over the past 20 years or so, and how we expect things to be different as far as side effects go. This, for people who are unfamiliar, is a CT of the chest. So it's really a slice looking at your lungs, your heart, your lung on the side, and your ribs all around. Traditionally, radiation would be done pretty simply, where you could have something as easy as one radiation beam coming from the front and one radiation beam coming from the back. And you have a pretty even distribution of your radiation treatment through pretty much this whole slice where you receive the treatment. Where in these cases, we may expect a little bit more side effects as far as the skin goes, as far as the heart, kind of throughout this whole area. And again, for those of you unfamiliar, where we're looking at these doses, kind of you'll see the higher doses are this red here, where it gets a little bit more even with the yellow, and the low doses are in the blue. So kind of looking at the far left, that's how radiation had been done for many years before computers or some of this planning technology. And we still use it occasionally in the setting of emergencies where we need to get somebody started pretty quickly. We then move over here to the middle picture right here, where we have a little bit more advancement, and you can see this tumor is contoured right here, right over here, and we put a margin on that in that red right there. Here we use multiple radiation beams coming in several directions, where we're better able to target that tumor and spare some of these normal healthy tissues. We do see a little bit more of this low dose spread around. And another way that we can do the treatments is with something called IMRT, intensity modulated radiation, which you may see or read about in this pathway. But this helps us, again, better delineate where we want to avoid, like this other healthy lung in this patient, and use an arc of treatment where radiation is on throughout this whole arc right here, and deliver radiation in a slightly more conformal or contained way to reduce tissue damage otherwise. So that's what happens in that in-between time between when you're here for a consultation and simulation and when you actually come in for treatment. So that's just a picture of what's happening. And the next step is actually when you're coming in for your radiation. Radiation is usually given Monday through Friday, 5 days a week, for a total of somewhere between 1 and 9 weeks. And that number depends on, again, what type of tumor you have and what the goal of treatment is, how we're coordinating this with surgery, with chemotherapy, and any other treatments. So there is a wide range of treatment times and deliveries. Your radiation is delivered on something called a linear accelerator. Again, this is for the external beam radiation. So this linear accelerator, where the radiation comes out of this head right here. A common question that we do here is, does it matter what kind of machine I get, or what is the machine that I'm being treated on? And I bring this up because I want to say most modern machines that we have, that we see in this area, they are all able to deliver the same type of focused radiation treatments that are applicable to most people. There are a few special circumstances that I will talk about at the very end where we have specific machines for specific reasons, but for the most part, all of these machines will be able to deliver the treatments that your oncologist is asking for. I think this is one of the areas of the biggest mystery of what does it actually look like when I receive radiation. So I brought in a video to demonstrate this. So kind of what the process looks like. Normally, for those Monday through Friday, 5 days a week treatments, I expect that you'll be here for about 20 to 30 minutes in the department. Depending on where your treatment site is, first thing you would do is go back to the dressing room and change into a gown, unless it's a part of your body that doesn't require you to be in a gown. Once you are in that gown and headed back to the machine, this is really what that process looks like. So the therapist will bring you back to the treatment machine. They will help set you up on a table, which may have a mold. If they made that for you on the first day, it may have that mask, really whatever set of devices you had for your CT mapping day. Once you're in that position and comfortable in that position, we will get you to your actual treatment position here. This is where those little Sharpie marks can help line you up on a day-to-day basis before the therapist steps out of the room and does some imaging to make sure that you're lined up on the inside as well as the outside. So here you can see that a CT was done and that the therapist is matching up your internal organs as well, your spine, your heart, your lungs, to make sure that you are in the position that we intended for your treatment. Depending on the type of treatment, your doctor may look at this film immediately or by the end of the day to make sure that everything is set up correctly for your next treatment as well. During this treatment, you will not actually see a laser. This is just a depiction of what the radiation looks like, but you will not see the radiation. You will not feel the radiation, and I don't expect that you'll feel any different while the radiation machine is on versus when it's off. So during your radiation course, this machine will move around you, and also people ask if it's an overall open machine just because of claustrophobia, and you can see that you have a lot of space around you. During this whole time, your therapists are watching you and monitoring you from outside, and they can see you and hear you in case anything is concerning for you while you're on the table or if you need to get off for any reason. After your treatment, the therapist will help you come off the table, go back to the dressing room, and go on with the rest of your day. Usually once a week, your physician, as well as maybe your nursing team, your radiation oncology treatment team, will bring you over to the clinic side to see how you're doing as far as you're checking your vitals and checking on your side effects from radiation treatment. I did want to mention a little bit about internal radiation, since that's a slightly different process and will not be using that linear accelerator. So internal radiation is something that we have available for specific types of cancers, usually endometrial cancers, cervical cancers, and prostate cancers, where instead of having radiation delivered from outside to in, you will have radiation directed from inside out. Depending on the device that you use, you may be awake or asleep for the procedure, depending on if something's being implanted, just inserted temporarily. So that's something where if your doctor recommends this, they'll go over what to expect as far as any kind of sedation, any kind of anesthesia, and how long this process will take, how long something will be implanted in you. For our gynecologic cancers like endometrial cancer, there's radiation that can be delivered via something called a vaginal cylinder, where that's inserted into you in the department, taken out before you leave. And for prostate cancer, there are some permanent implants, such as radiation seeds, that may be delivered to help treat your prostate cancer. So if that's part of your treatment course, there's a lot more about kind of the process, the side effects that your doctor would go into. I think probably the most common question that I get asked in all of this is on the side effects side. What should I expect as far as radiation treatment? What will I feel? How I feel a day of treatment? What side effects will build up throughout this? And I have to say, this is a hard question to give to a general audience because the side effects depend so much on multiple factors, mostly on the site where we treat, whether that's a head and neck cancer, whether that's a cancer of the lung or the GI tract. It varies. It also depends on if you had surgery and if you are receiving chemotherapy or if you've had chemotherapy, because those side effects can still be there and also make the radiation a little bit tougher as far as the fatigue goes. I do mention fatigue since that's a side effect of radiation that I can expect no matter what part of the body I'm treating, whether that's a breast, whether that's an arm, the fatigue can be there. The level of fatigue will depend on, again, if you receive chemotherapy or not, where on the body you're treating. So that one is always there, but to a different degree. I do expect that the fatigue does build up over the course of your treatment. So you may feel okay the first couple of weeks, and that slowly increases over time. And I normally tell patients that the best things that we have for fatigue are hydration, making sure that you are taking in enough nutrition, enough calories, enough proteins to help with your treatment during this time. Maintaining a normal schedule can be helpful. So trying to get up in the morning at a routine time, trying to take naps if you need to, kind of going to bed at a normal schedule, that can help with staying on track with your day-to-day life. And one of the most important things that we've seen, or most helpful things that we've seen with the fatigue, is actually exercise. Doesn't have to be anything strenuous as far as exercise, but routine 20 minutes of walking during the day, 30 minutes of walking during the day, something light, something like yoga, but having that exercise is one of those things that's been proven over and over again to help with the fatigue from both chemotherapy and with radiation. The other general side effect that I can speak to is that the radiation area where you're being treated, you may see a suntan or a sunburn develop over the course of your several weeks of treatment in that site. I don't expect you to have skin changes outside of the area you're being treated. And I mention this because when we see radiation changes, we can almost see the area where we're treating. So when I see a breast cancer, I would only expect that that the sunburn or suntan happens in that site, but not outside of that area. Depending on the type of radiation you receive, how much radiation you receive, this can go from a mild suntan or sunburn to even peeling, even itchiness, even a lot of discomfort in that area. So kind of that's one of those things that we keep track of on a week-to-week basis when we see you and talk about skincare. The other question I get asked a lot is about hair loss. And this is something where I want to say the hair loss that we expect, just like the skin changes, are going to be only in the area that we treat. So if I am treating your breast or your pelvis, I don't expect to affect any of the hair at your head. But if you are receiving radiation to your brain, to somewhere in your head and neck, we can see hair loss in that area. The duration of your side effects, how long they last, whether it's a couple of days, a couple of weeks, a couple of months after your chemo or your radiation, really depends on all the factors we had talked about before, as far as what kind of treatments you're receiving and where those treatments are. And this is one part where I spend a lot of time when I see patients discussing what I expect from the short-term side effects as well as the long-term side effects. And I think it's a very important part of the discussion, because the more that you know about this going in, the more you can prepare for it and kind of know what to expect and know what to tell your caregivers as well. I had mentioned earlier on that there are a couple of special treatment procedures that we do have dedicated machines for, and may be different than our standard external beam radiation therapy that we discussed with them Monday through Friday, 5 days a week. Two of these are very similar. They're called stereotactic body radiation therapy and stereotactic radiosurgery. And what both of these are, they are high-dose, very focused radiation treatments to a small area, whether it is in the brain, where we use the term SRS, or in the body, where we use the term SBRT. In these situations, radiation is, like I said, delivered in a high dose, and because we are giving a high dose to a small area, we can do the treatments usually in somewhere between 1 and 5 sessions instead of multiple weeks of treatment like we do for many other body sites. This is an area where we're having more and more research done to see what indications can we use this for. Currently, we have good data for lung cancer, where we can treat very small lung cancers in patients who may or may not be eligible for surgery, even for the small lung tumor, and treat that with a high dose of radiation. Same thing for bone tumors or bone metastases, where they've come from another part of the body. In some cases, we can use this high dose radiation to help control that disease and reduce the number of times you have to come for treatment. There is growing evidence in the world of prostate cancer, as well as in liver cancer and liver metastases, to use these high doses of radiation. And this is one of those places I would say it may require a specific machine to do this, to help with that high dose treatment, to help with the accuracy of treatment. So these are a couple of pictures of what that would look like in the body. And then I want to go into a little bit more about stereotactic radiosurgery. One of the things that you may have seen on the title at the very beginning was that I work here in the radiosurgery department with gamma knife treatments. This was actually one of the things that brought me down to Northside Hospital from my residency to work with a gamma knife. The gamma knife is something that we use for treatment of brain tumors, both malignant and benign brain tumors. And it's actually been around for at least 50 years. But obviously it's gotten updates along the way, and we've had a lot of changes now that we have MRIs and computers as availabilities to help us with treatment. The gamma knife, if you are referred for discussion of this, I do want to say that there's actually no knives involved. This was invented early on by a neurosurgeon, so everything is kind of surgically driven, but we use radiation instead of a knife to really mimic what surgery can do with doing high doses to very small areas. Usually treatment for brain tumors on the Gamma knife is done in 1 day, but can be done up to 5 days in 5 days, depending on the tumor itself and if it's close to any sensitive tissues. On the right here, you can see what that Gamma knife machine actually looks like. And if we zoom in here, this is where you would be lying down on the table with your head right here towards the treatment machine. There's 2 ways where this treatment can be delivered as far as a way to keep you in place during the treatment. On the top here, you will see what's been available for, like I said, the last several decades as far as putting a frame on your head to help keep you in place during your entire treatment. In this case, there's pins that go to the very front of your scalp and the very back of your scalp. They are not going in your brain. They're touching the very surface of your skull to help keep this frame in place during treatment. For some patients, we may be able to use a mask instead of this frame. And this mask is almost like what you saw earlier with that CT mapping, but it's actually a much tighter fitting mask. This mask is able to keep you from wiggling a little bit more than the last mask. And also we put a little tracker on your nose in this case, so we can see if you have even a fraction of a millimeter of movement, and the machine can pause the treatments depending on your movement. So this is something we use for treatment of brain tumors specifically. And the way that radiation works for these brain tumors, and the reason that this works so well with a high dose accurate radiation, is because of the way that the machine is made. I normally have my patients, if I don't have a visual, imagine a colander on their head, which is pretty much this dome right here, where there's approximately 200 different slots in that colander or in this dome right here. And if you shine a flashlight through any one of these and you have them all converge, they will all converge on one very small spot, somewhere between 4 millimeters to 8 millimeters to 16 millimeters, depending on which size holes we use. The reason that this is so effective is because each one of these rays has such a little dose of radiation going through it, but when you have them converge in one spot, that spot receives a full dose of radiation, and you have very little damage to your normal or your healthy brain tissues. For tumors that are bigger or smaller, we can change the size of these holes, and we're able to shape treatments to not just a sphere, but we can even block out some of these holes or change the sizes, like I mentioned, to help reduce the dose if your tumor is close to a very sensitive area. And right here, I just have a couple of examples, like we showed with the CT of the chest and the body earlier. In the brain, we can treat a small spot with a very targeted radiation beam, or even close to sensitive structures like the back of your eyes or your optic nerves. In this case, we can treat both brain metastases and with some benign tumors, like this one on the left right here being a benign tumor. And this has actually been a great advancement because we're able to treat more and more of these localized metastases and reduce our need for whole brain radiation, as well as the potential changes and memory that we can see with whole brain radiation. So this is just one of the areas I wanted to highlight, since that's our big focus here with Northside Forsyth and our Gamma Knife program. A couple of last common misconceptions that I wanted to mention, and these are things that I get asked probably every week, is the first one is, if I get radiation, can I be around other people? Can I be around babies? Can I be around pets? All of those. And I want to say, with this external beam radiation, you can be around other people. You can pretty much have your normal day-to-day activities as far as interaction with other people. There are specific cases where we do give you precautions as far as being around other people, sharing utensils, sharing bathroom spaces. That's if we treat you with a radioactive pill or a radioactive injection, not something that we see very commonly, or if we do implants with those seeds that we talked about with prostate cancer radiation. But with the external beam radiation, you can absolutely be around other people, family, children, etc. The other question that I get asked pretty often is, if I get radiation now, can I ever have it again? And the answer is yes. And that's for both if you have a cancer or a recurrence, a separate cancer, come up in a different part of your body. We can deliver radiation to one part of your body once, and we can absolutely deliver it to another part of your body if needed. In some cases, we can actually deliver radiation to the same spot over again. There may be increased risk that you would talk about with your doctor, kind of depending on how much overlap there is with the prior radiation area, also depending on how long it's been since your prior radiation. But this is one of those common misconceptions that having radiation once does not prevent you from having it again. I know there's probably going to be a couple of other big questions that come up in our Q&A session. I just wanted to mention these two big ones. Also wanted to introduce our treatment team, or your treatment team, which would involve your radiation oncologist, the nurse practitioners and physician's assistants and nurses who work in the clinic with us, the radiation therapists who will be the ones, for the most part, on a day-to-day basis who you'll see during your treatment, and the dosimetrists and medical physicists who work behind the scenes to work on that treatment planning to make your plan possible. Additionally, we have other resources within the actual Cancer Institute, within Radiation Oncology, to help with the whole process. And this includes social workers, includes navigators to help you with the process of seeing your surgeon, your medical oncologist, us. The nutritionists and dietitians are so incredibly helpful for some of our patients. Some of them we refer at the beginning, depending on the cancer, sometimes along the process. This is someone you want to see to help with balancing your diet and helping with some of the energy and the protein for treatment. We do have speech and swallow therapists as well, mostly for head and neck cancers. And one of the groups that we work with a lot is physical and occupational therapy, just because with cancer, often you have surgery, you have chemotherapy, radiation, and these are teams that can really help you get back to as close to your baseline as possible. So just wanted to introduce those groups and open it up for questions from Dr. Ben, or really from you guys, but through Dr. Ben.
All right, so thank you for this great presentation here. I would, Isabella, so basically there's some questions. I don't know if Katie's there. We can go on with the questions that I've got from the participants here. So I'll start with the first question I have here. Does receiving radiation therapy increase my chance of developing secondary cancers? And does this depend on where the initial radiation is received?
So yes, it's a good question, and I'm glad you ask it because this is part of my side effect discussion with most of my patients. So radiation itself, like you mentioned, does give you a risk of a potential second cancer down the road. What this depends on is, one, where you're receiving your radiation as far as the part of your body, whether it's your breast, your GI system, your head and neck. So it does depend on the site of your radiation. It depends on how much radiation you receive. And it also depends on your age potentially. So I do tell my pediatric patients, my younger patients, that it often takes about 10 plus years, 20 years potentially, to develop a second cancer from radiation. So the younger you are, it is something that we see a higher risk develop over time. So when you meet with your radiation oncologist, depending on the site that you're being treated, they'll often be able to ballpark a number for you as far as your risks go, whether it's as low as 1 in 10,000, 1 in 1,000, or even potentially close to 1%. But we rarely see it greater than 1% risk of having a second cancer from treatment.
All right. I have a second question is, does radiation affect my fertility?
So radiation can. So again, with this side effect, we look at where you're being treated. So if I'm treating you to your breast, then the chances of affecting your fertility incredibly little, since we're far away from your ovaries. If we are treating your pelvis, though, it is something that we consider, and if it is something that may be an issue, we can talk to you about really having your eggs harvested beforehand, potentially having your ovaries transposed, removed beforehand, before the radiation, since we know it can be affected. One thing that I do bring up here is that it's very important to not be pregnant or not get pregnant during your radiation treatment as well. So if you are in that age where it is a possibility, that's something that we would talk to you at your very beginning consultation for regarding how important that is and methods to help reduce the risk of that.
Okay. Moving on to the next question I see. Is gamma knife radiosurgery specific to brain tumors? Are they researching ways to use it on other tumor sites?
It is specific to brain tumors currently, and the reason for that is you could see that that depiction or that picture earlier, where it's almost like sliding into a dome over your head, and radiation can only be delivered from the gamma knife in that specific area. There is actually a different technology. I believe it's called the gamma pod. It's for breast cancers. Again, you can imagine it's going to be a pod or a cone that's very specific to the breast. So it is currently used for brain tumors, and that's just because of physically how that structure is made.
Okay. Another question I have is a patient or a participant, I should say, had received radiation a few years ago and still suffers from dry mouth. Is there anything you recommend? I'm assuming probably head and neck.
I would also guess that. So dry mouth is one of those things that we can see pretty commonly after head and neck radiation. I see Dr. Vin nodding as well because unfortunately the parotid glands and the overall salivary glands are very sensitive to radiation. So the doses that we use for curative treatment of head and neck cancers often will exceed what the parotid glands and other salivary glands can tolerate. As far as dry mouth goes, the common recommendations that we have are really to and make sure that you always have a bottle of water with you, some water with you to help with that dry mouth, to help drink, to continue those baking soda and salt rinses that we talked about during radiation to help keep the mouth clean, to help reduce that sticky saliva that can stay in there. Some people have found help with mouth sprays, such as biotin, to help with the moisture in there. There's a couple of different sprays on the market or lozenges on the market to help with that saliva. And the other thing, anecdotally, that I've learned is some sour candies, lemon drops, can really help with pulling that saliva, that puckering feeling that you get when you suck on those candies. That can actually help drive some of that saliva. So those are kind of the big things that we would look at. The other important thing that I want to mention there is also having routine care with your dentist, because having a dry mouth does put you at increased risk for dental cavities. So making sure that you're having those routine checks to make sure if there is anything that's developing in your teeth that you have it taken care of.
Gotcha. I don't know if there's any more studies, if they're looking at, I think prior to that, if they were giving patients prior to radiation medications to reduce the risk of, some of the dry mouth. Was there anything else you think is ongoing studies to reduce the risk of dry mouth?
I think I know you've mentioned like a couple of studies looking at just giving you something beforehand or during radiation help. I have not seen a lot of evidence for any new medications, but I can't say that that doesn't mean there aren't studies going on.
So maybe, did you mention palifermin? I think that I've seen sometimes they use that to, reduce mouth sores and to reduce that risk on patients in radiation oncology. So that's another thing maybe can potentially be utilized. So in interest of time, I'm going to move on to the next question. Another participant asked about hydration before and after radiation treatment. She seems to be getting treatment for breast cancer, and she's asking hydration before and after. Do you recommendations?
So with breast treatment, it's not really important as much for timing for us as far as do you do it right before, right after. Really, the recommendation is staying hydrated all through the day. I know with chemotherapies, and Dr. Vin can speak to this, there are some chemotherapies where we really encourage you to hydrate right afterwards to help kind of move those fluids along. But from a breast treatment, I would say really no time of day that matters. When we treat pelvises, GYN or GU, we may tell you to hydrate a lot beforehand, and that can help fill up your bladder and move some of your other more sensitive organs outside of the treatment area. But as far as hydration goes, otherwise, I don't have any kind of timing recommendations.
Okay, so a question I'm getting repeatedly here is how to choose a radiation oncologist and a medical oncologist. So should I say who do a cancer support committee? So
Yeah.
I think they're asking, how do I choose a good radiation oncologist or what to look for? Accreditation or, I think that's the question I'm getting. So if you want to elaborate.
Not a question I expected to hear.
What questions should the patient be asking when looking for radiation oncologist? I think, and there was a question from medical oncologists too, so I'm going to try to fill in a little bit here, is I think the first thing is to look at their credentials, where they're trained. Is it most of the oncologists or medical radiation oncologists, if you're looking at a reputed institution as one, where they're working, what their experience has been, is there any special area they're working with that may be related to your cancer. So I'd basically start with that and recommendations. Usually a referring doctor, your primary care doctor, or your surgeon, they also have good recommendations, but sometimes it's good to go out and look and to see if there's patient experiences and, look at what kind of background they have, and sometimes you might have to actually see them, unfortunately, to get their personality and maybe matches. Sometimes it's just not meeting credentials and education. It's what works for the patient, whether you're a good fit, bedside manner. All these you can get on the website. So.
No, I think I would second everything that Dr. Vin said because as far as medical oncologists, radiation oncologists, most people that you would be seeing at a reputable institution are going to be board certified physicians. So they know what they're doing. They have a good understanding of what the processes are. They are, like I said, in an institution, they are often having peer checks, having conferences with other radiation oncologists, other medical oncologists, meeting with surgeons to know that they understand what they're doing. So on a basic level, like you said, credentials, education, really good to have as a background. But I think the biggest ones are going to be kind of getting those referrals or recommendations from the other doctors that you have in your group. So your surgeon who's probably worked with multiple oncologists, your primary care who's probably worked with a few during the process. So recommendations are great. And I think the other thing is if you meet them and even if they have the best credentials and you don't feel like it's a good fit, it's absolutely okay to go see another doctor. We want you to be comfortable with who you're seeing, and also you're going to be seeing us routinely, regularly for treatment, for follow-up. So it's somebody who you feel like is listening to you, understanding you, and kind of has that bedside manner, has that connection with you.
Right. I agree. There's another question. Are there any medications that are contraindicated while I'm receiving radiation?
This one, I'm going to say generally no. So most of the medications where you may have a contraindication are again going to be back into the chemotherapy world or kind of Dr. Vin's world of medical oncology. Most patients, I will say, you stay on your exact same medications throughout your radiation course. The only exceptions that come to mind right now is if you are getting an invasive procedure, such as internal radiation, they may tell you to hold your blood thinners for a few days, depending on the blood thinner. And the other thing that we tend to see is actually holding off on any high dose vitamins. That's one of the concerns where radiation early on, I mentioned that radiation works by causing DNA damage. That DNA damage is usually via oxygen radicals or using oxygen to help with that damage. So high dose antioxidants, there's been some theories and concerns that high doses of vitamin C antioxidant may decrease some of that effectiveness of radiation. So we do always encourage you to bring a list, include those vitamins on that list to see if that's something that we may have to pause during treatment.
Okay. I think that's the most of questions I have. Let me check if anything. So, and adding to that, medications during radiation, of course, if you're taking, I'm assuming that's a general question about, it's not medication that's related to cancer treatment, because there are times when you need to take the medicine along with radiation, and there are times when, for example, you're doing chemotherapy, you should stop during doing radiation. So I'm assuming the question applies to cancer treatment medications. So anything that's related to cancer treatment, you want to talk to your medical oncologist and confer with your radiation oncologist. But I think the question is in general, like blood pressure, other medications we were talking about. Let's see. I think that's all we have. Thank you very much for taking the time, Dr. Zhang, and thank you all the participants who take the time on their beautiful day outside to be able to, or for the most part, I should say beautiful day, but taking the time to be out here and, listening to us, and, look forward to discuss this again at some point.
All right, we'll bring Katie back at this point from the cancer support community.
Yeah, thank you both. That was a great presentation, and thank you guys both for answering those questions. Thank you everyone who submitted questions today. I did want to, before we wrap up, just remind everyone that a recording of today's presentation will be up on our website, most likely next week, and that's cscatlanta.org. And of course, you can visit that website to see a complete list of the virtual oncology support programs that are offered and to see recordings of past programs. So before we wrap up, I want to throw it out to you, Dr. Vin and Dr. Zhang, for any final remarks, and I'll toss it out to you, Dr. Vin, to start us off.
I think, essentially this gives a good introduction as to, basics of radiation and what to look for and some basic effects, side effects, and I think it's a good introduction for patients who have family members who are actually receiving radiation. So I think the video on the website, for if there's any other questions, references, you can go back and look at it. I think that's all I have. But Dr. Zhang, anything else you want to add before we?
No, really just to say thank you guys for joining. If there are questions, the cancer support community website is going to be a good place not only for radiation, but for other parts of your questions, other parts of your cancer care. But at the end of the day, I think it's really important if you do have questions for your radiation oncologist or kind of finding one, just reaching out to people in the community who've worked with us, worked with other doctors, and really getting in touch with somebody to have your questions answered.
All right. Thank you
All
both.
right. Thank you.
Yeah,
Thank
you.
you.
Thank you guys for sharing your time and expertise for today's program. We hope to see you all again soon. Thank you, everyone. Take care.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.